Good afternoon, everyone. As the panel gets together, we'll get started. Dr. Sunil Agarwal could not make it, unfortunately, due to a family event, but we have the rest of our panel here, and we'll have it partly as a lecture format, but also some discussion. So with that, I'd like to get started. I'd like to thank the organizing committee for the opportunity to participate. It's a great honor. And to Swami, of course, for his blessings, and a special thank you to Dr. Keshav Nayak for organizing the US contingent. We have the slides. So when I was asked to present as an interventionist, I was thinking it's the last thing. As you know, we're so far down in the preventive theme, although we always try to prescribe preventive therapies, and we have a very good preventive cardiology clinic, so we do give focus to preventive cardiology, but he said the conference is on prevention, so your topic must be on prevention. So with that, I decided to speak on inflammation, and my interest in that is largely, partly because my entire practice focuses on coronary artery disease and complex coronary artery disease, but also in coronary spasm, microvascular angina, and I've had an interest in vascular biology, having done research over the years into that. So with that, inflammation, I think, is a very topical subject, particularly when it relates to coronary artery disease. And in fact, as I was preparing for this presentation, this paper was presented at the ESC and published this month by Paul Ritka. Many of you will know that he spent his whole life talking about inflammation, and he came up with this idea of the term Smurfless. Those of you who have children will know the Smurfs are these blue little characters that the kids watch cartoons on. But Smurfless meaning standard modifier risk factor less. So people who don't have, we've been talking about diabetes, hypertension, hyperlipidemia, or smoking, but there are many, many patients who do not have any of these risk factors. And his thesis has always been that these patients have underlying inflammation through other mediators. And I'll show you the data he's presented. But it's always time to listen to the lay press. This is an article published in The Guardian, a UK newspaper, just in July of this year, talking about 5 free and easy ways to fight chronic inflammation, even without doctor's note or a thick wallet, which is very appropriate for this meeting. Anyone can engage in these scientifically backed anti-inflammatory activities, and I'll come back to the 5 free and easy ways. But let me take you back to your medical school days and your textbooks. When you used to read textbooks and opened Brownwell's, these figures would be in there, which is the classic model of atherosclerosis. And you'll remember that the earliest stage of atherosclerosis is endothelial injury and entry of lipid. But soon after, you get inflammation within the vessel wall. You get classically the monocytes and macrophages and T lymphocytes entering the vessel wall. So we've long known that inflammation is important, but we've not known what to do with that. But we also have learned over the years, and this is when I was doing my research, that inflammation is independently predictive of outcomes, independent of Framingham risk score, independent of cholesterol values. You can see that no matter what your clinical and lipid profile, the higher your HS-CRP, the worse your prognosis. And Dr. Narasimhan alluded to that earlier, that he normalized his CRP, HS-CRP, by taking lifestyle measures. So here's the data from Dr. Paul Ritka, published this month, where he took data from the women's health study done out of Harvard over the years, followed them for 30 years. These were the Smurfless women, so women who had no conventional risk factors, and then measured their high sensitivity CRP and followed them for 30 years. And you can see that there is a dose response curve here. The higher the CRP, the worse their outcome, and the threshold seemed to be around an HS-CRP of 3, where the outcomes became much worse. And this really supports the idea that inflammation is a clinically useful entity to treat. And this month, again, he published a subgroup analysis from the Jupiter trial. You remember Jupiter was a very large trial of 10,000 patients in whom there was no indication for giving lipid-lowering therapy, but he did randomize them according to their CRP values. Patients were randomized to placebo or lipid lowering based on their hs-CRP alone, and showed that there was benefit. And in this paper, he looked at those who were Smurfless, so without any standard risk factors, and showed 38% reduction in events if the CRP was elevated. So there's a very strong body of evidence that we should treat inflammation. And remember, inflammation is systemic, but perhaps the largest organ in which this occurs is the adipose tissue, which is why the central obesity and periorgan obesity is so harmful, in part because it is really the site for inflammation. And then that acts on the liver, which then releases the CRP that we measure. So having hopefully convinced you that inflammation is important, how do we detect it? Well, first of all, there are many, many biomarkers, and I've listed just a few, but the ones that are most useful are CRP. Why? It's because CRP is very stable. There is a very standardized assay, and the most research has been done using CRP. And for the purpose of this talk, we're really talking about high sensitivity CRP, where we're detecting subclinical inflammation. And we can also detect inflammation in vivo now with high resolution imaging. This is OCT. You see this homogeneous area of a stable fibrotic plaque, but you see these very, very bright areas with a sunray appearance. That is monocytes within a plaque. So we can see with high-resolution imaging inflammation. Non-invasively, we can also do it. We've been doing it with CT for many years, looking at low attenuation or fatty plaque. But nowadays, with contemporary imaging, with PET scanning and AI-enhanced CT imaging, we can also detect pericoronary inflammation. So I think in the future, we will have non-invasive tools to add to our knowledge of not just plaque burden, but plaque inflammation. And I think that's going to change our practice. So now that we can detect it, how do we image or treat it? Well, in the land of Ayurveda, of course, we've known about the benefits of phytonutrients like turmeric. But in reality, there's very little trial-based evidence. There are small trials suggesting that you can modify inflammation with turmeric, but we now have large-scale trials with pharmacological agents, which really prove the concept that treating inflammation matters. And the first trial I want to share with you is this CANTOS trial that really proved to us that treating inflammation without doubt matters. This trial used a novel biological agent called canakinumab. This is a human monoclonal interleukin-1 beta antibody. It was actually developed and used for orphan diseases, these very rare conditions where inflammation is central to it. But Paul Ridker had the idea of deploying it in stable coronary artery disease patients to see if he could prove the hypothesis that treating inflammation matters. And indeed, what you see is over 5 years follow-up, treatment with canakinumab reduced major adverse events, and the curve started separating around the 1-year mark. And so there was about a 15% reduction in major adverse events. You may wonder why we're not using the drug then if it's so effective, and the answer is because there was a signal for harm. There was a slight increase in serious sepsis and infections, so it was never marketed. You've got a very expensive biological agent with a signal for harm, but it was proof of concept that treating inflammation is effective. But you know, cardiologists never sit still, so they said, okay, well, now that we've proven treating inflammation is effective, why not try another drug? And now there are 9 trials with colchicine showing benefit. This is a meta-analysis published just this year showing that there is approximately 12% relative risk reduction in these 9 trials in favor of using colchicine. Of course, you know that colchicine has some side effects with some GI intolerance, but at low doses, it can be used. So we now have 2 drugs that have shown effectiveness in treating inflammation in stable coronary artery disease. And with this data, the FDA has now approved colchicine for the treatment of secondary prevention of coronary disease. However, it gives it a Class 2 recommendation until we have more data. The Class 2 recommendation, of course, comes from the ACC-AHA. So, as always, we need more data, and there will be more data in this field. There are 2 very large trials of colchicine going on right now. There's a 10,000 patient trial in diabetics for primary prevention and in acute coronary syndrome patients for secondary prevention. And indeed, there is trials from novel biological agents like interleukin-6 antibody in the Artemis and Zeus trial. So I think there's going to be a whole body of evidence, and hopefully we will be much better informed about the role of inflammation. So how do we do it right now? What do we do with our patients? Well, let me take you back to this Guardian article. Remember, it said 5 ways of treating it. So the first 2 are very interesting. Spend time in nature. And this is evidence-based, by the way. Everything was cited with some papers showing efficacy. And then the second is art and music. At least in the US now, these come under the category of social prescriptions. Many states are doing social prescriptions for such things because of the loneliness epidemic. People don't have access to interactions, and so this literally has to be prescribed now and has some efficacy. Exercise we've known long about, but really for this meeting, this audience, I was really fascinated to see that they were promoting spirituality and supporting others. In other words, community service, or what we would call seva. So in this Guardian newspaper in the West, now we're talking about spirituality and seva to treat inflammation. So fascinating and very relevant. In terms of therapeutic agents, I've already told you the colchicine has proven benefits. Statins in the Jupiter trial showed benefit in patients. So I would encourage you, so once you stabilize patients who have on standard therapies, and particularly in premature, you're talking about these patients under 40 having major events, I suggest to you that maybe measuring hsCRP routinely in these patients is a good thing. And if it's elevated once they're on statins and all the other therapies we give, then you may wish to directly treat the inflammation. There's a lot of interest in GLP-1 agents like semaglutide, of course, for weight loss. It now has a class 2 recommendation for coronary artery disease in the United States. And I suspect that a lot of its effects are not just from weight loss, but from reducing inflammation. And of course, we will have potential novel agents coming up. So with that, I'm going to conclude and leave you with some final thoughts. I hope I've convinced you that inflammation is causally linked. It's not just a bystander in atherosclerosis. We have readily available biomarkers and imaging, intravascular and non-invasive imaging available. Remember that a threshold of hsCRP of 3 is what we should start thinking about treating. And lifestyle modification, including spirituality and seva, do make a difference, and pharmacological interventions will be growing in numbers in the coming years. With that, I'll stop, and thank you very much. And maybe we could ask our panel a few questions regarding that. Keshav, I know that you are, of course, we're interventionists, and it's not something we think a lot about, but is hsCRP anything that you consider measuring?
Yes, absolutely. We try to predict risk. So we went in all our patients. We look at all inflammation markers and target therapies for that. But as you said, we're getting more and more research, not only in coronary artery disease, but also valvular heart disease with chronic inflammation.
Absolutely. In fact, aortic stenosis is thought to be an atherosclerotic-like process, right? So, and there is evidence of inflammation there too. Dr. Bhuwaneswaran, any comments on inflammation? No? Okay. Good. Well, any questions from the audience? Because we do have time. Do we have a microphone? Yeah, you're loud enough. I can hear you. So the question is that the ACCHA give it an indication, although FDA have given it a secondary prevention indication, but not primary prevention. I think some of that is semantics. I think primary prevention is a lower risk profile, so the numbers needed to treat would be much higher. And so I don't think we should be absolute just because there isn't an indication. I think generally it's a good idea, particularly in those so-called SMRF it's a new term that we'll get used to. Those SMRF patients, if they don't have standard risk factors, I would definitely look for it. Of course, there's a lot of interest in lipoprotein A. There is a lot of sort of various therapeutics coming down as additional treatment targets, but I would look for CRP. At least it's something that you measure and you inform the patient that way. What's that, Dr. Garg? No, we don't, but we do it in our premature CAD patients routinely. So we measure lipoprotein A, hsCRP. Lipoprotein A mostly for what's to come. As you know, there are therapeutics being developed, and hopefully even this year we may have the first trial for clinical endpoints. and CRP mostly because I think we do have some patients in whom, there's no obvious reason why they're getting atherosclerosis, and at least it gives us some idea. We're not sort of necessarily immediately jumping to therapeutics in them, but it just gives us some sense of whether there's underlying inflammation. So mostly in our premature coronary artery disease, so the younger patients, not so much in the older patient population. Any other questions? There's a question back there, I think. Yeah, I think there's a microphone coming up to you, and I think your question is coronary calcium scoring as a way of a risk stratifier. Is that correct?
Yeah, so I just wanted to make a comment. We've been talking a lot about calcium scoring in the previous talks. What I've noted in my practice is that a lot of the younger patients, the 20s and 30s, when we do risk stratification for them, the calcium score is often very, very low to negligible and sometimes even zero. But when you do a complete CTA angiogram on them, they often have significant atherosclerotic disease. So I just wanted to see if anybody has any comments or if they've noted something similar in their practice. It's not completely reflective of the talk that we were talking, but just in general.
Sure, I think there may be a talk coming up on CT and so on, but I personally agree with you that I think coronary calcium scoring is perhaps not as useful as CTA.
Yeah, especially in the Indian population.
Absolutely. I mean, I actually, as an interventionist, I've never done coronary calcium scoring. That's often done in primary care and so on. But by the time they get to us, I always say that, we need to know plaque burden. And so I think CTA, because of the quality of CTA has improved so much now, that's really what we want to know. Hopefully I've heard you correctly and answered you correctly, but I'm sure you can find other experts on the topic. Any comments on that?
Yeah. Dr. Abhiram Prasad has told that inflammation is the cause, and it is not only the cause, it is the consequences also of coronary artery disease. He presented with so many studies and all, and Jupiter study, as he told, that it's a CRP value more important. So many times patients will ask, when can we take a statin and all. So this Jupiter study could give an answer also that inflammation is there. So inflammation is one of the most important thing that is causing the coronary artery disease. I am very grateful for your enlightenment. Any question now? Now, Dr. Keshav Nayak will present his paper.
Thank you very much. Sairam, everyone. My humble pranams at dear Swami's lotus feet. As an old Uti school student and primary school student here in Puttaparthi, I'm inspired to share two quick stories that Dr. Rao approved that I can share. And I do want to thank you for inviting me. Back when we would visit Swami would always be really happy that we came to Puttaparthi. And I would urge all of you to do the same as you were asked today. And Swami's very happy that you're here visiting him in Puttaparthi. He still manifests every day now after 2011. I can tell you once, my grandfather from Mangalore, who's Dr. Kamat's father, she's my aunt, my mother's father once hadn't come seen Swami for a little bit. So Swami sent him a message through other devotees saying, "Pai, did you forget the directions to Puttaparthi?" And that's how much Swami loved all of us visiting him, and for the divine love and compassion that Dr. Desai mentioned. He wants you to visit. He wants you to visit Puttaparthi. So thank you for this grand opportunity for me to visit Swami. The other story is that Swami is the divine doctor. In my life, there's an incredible occurrence where Swami was my divine doctor, and he works through all of us as doctors taking care of his patients. But back when I was a medical student in Philadelphia, one late night I was riding my bicycle downhill at very high speeds, and I suffered a head injury. A dog leash caught my nose, bridge of my nose, and rendered me unconscious. Damaged the bike, and then my helmet was in pieces, and I awoke from loss of consciousness to my mother screaming, "Swami, Swami, Swami," with an ambulance nearby, and my grandfather happened to be visiting Philadelphia at the time. And on the way to the ER, I felt Swami's love and compassion. I knew he was there, and I'd asked my mother, "What's going on? One minute I'm with Swami, and the other minute I'm here lying on this road in a major accident." So I recovered uneventfully from that injury and went on to medical school, but my grandfather came back and saw Swami, and Swami called him in and said on the veranda and asked him to recount what happened to his old student, his grandson, to the students, to all the students. And he said, Swami, he had a bike accident. And then Swami interjected, "You know, I was there and I held his head before he could hit the ground." And that's exactly where it brings tears to my eyes that Swami is always with us. He's everywhere, and he continues to manifest in our lives so we can take care of his patients. With that, I do want to wish Swami a 100th birthday. I love celebrating birthdays for my patients, and Swami loved birthdays too, and he would make it a grand occasion for all of his students with fireworks and gifts and treats and cake. How many of you have 100-year-old patients? You're taking care of patients. I do too, and I often ask them, "Why are you coming to see me? You've already won the longevity lottery. I'm only going to change medications and hurt you or cause some concerns." But I actually did a TAVR, which next slide please, on a 103-year-old. I think Dr. Dash would criticize me, why did I offer TAVR, but he happened to be a pastor, and he said God, his boss, wanted him to have a TAVR and to continue being a pastor in his church. So after much review with the heart team, we thought he was a low-risk candidate, even at his advanced age. And we went to the operating room and did his transcatheter aortic valve replacement. And after I deployed the valve, his heart stopped, and he was in PA arrest. And here I looked at Swami, we cannot have a 103-year-old die on the table. And then I looked at Swami, God, he's your employee, and he's doing this for you to continue working for Swami, for God. And I did CPR on the table, and he survived. He worked 3 more years till 106 as a pastor. So this is where, as Dr. Jivanandam shared with us, we surrender to Swami with all of these procedures where you're doing high-risk interventions for very elderly patients, and you give it all to Swami. So let me talk about TAVR very quickly. This is the outline. And basically, this involves severe aortic stenosis. It's quite common, and we do balloon aortic valvuloplasty. And this is a historical slide, first done in 1985 by a French cardiologist who's revolutionary. He did a lot of things that gave birth to our field. And he would do this transeptally. He would go through the right atrium, across the intra-atrial septum, antegrade approach, and did this for over 15 years and got very good at it. And then came up with the idea of how do we fix the restenosis of the aortic valve after balloon valvuloplasty, and came up with a prototype of a stented aortic valve. In 2002, which is almost 23 years ago, first in man TAVR was performed. And to share with you, you would think industry would want to select the most low-risk patient. This turned out to be a 50-somewhat-year-old patient who was in cardiogenic shock from critical aortic stenosis with an ejection fraction of 10%. And he wanted to help this young patient, so he called up his investors and co-investigators and inventors in New York City, in America, saying, hey, I have a patient, I need to treat him, can I use this valve? And they all said, no, you are not going to use the first valve ever in a dying patient who's in cardiogenic shock and terminal heart failure. But he, after much exchange back and forth, they finally agreed on compassionate use. And he went ahead with all of his experience in transeptal antegrade valvuloplasty. He was able to do this and if we can play this. This is the original TAVR. The patient actually arrested after he crossed the aortic valve. And you'll see there's no cardiac motion here at all. Generally, what we do now, we pace the RV at 180 beats per minute to abolish systolic surge, so I can inflate a balloon with the valve mounted on it. This is the original first ever TAVR. And then after the valve was deployed, can you play this? You'll see the cardiac motion is restored, hemodynamics improved, and then as history has it, 15 minutes later, they were doing high fives in the operating room. And then an hour later, the French loved to celebrate with champagne. Everybody had champagne, and that was the birth of our field of TAVR, or transcatheter aortic valve replacement or implantation. And so that first, a year or two later, 100 TAVRs performed, and then now over 100,000 per year. And it's often a heart team approach. I'm very close. You would think I'm competing with my heart surgeon. My heart surgeon and I actually are very close, and we debate over every patient about surgical versus transcatheter options for our patients. And this is the development of TAVR over the last 30 plus years. And these are the valves that are available now. And I'll go quickly through this. Up on the top are self-expanding valves from all over the world. And then bottom are balloon expandable valves. And we have our own Indian made valve called My Valve. And I happened to meet them last week with Dr. Rita in the Whitefield Hospital. And quite an ingenious company that has really revolutionized the valve with all new iterations in their third generation octa-core and octa-pro valves to mirror the Edwards valves. And here's a important movie that I would like to show you. This is how we implant the valve through a femoral access, and we cross the stenotic aortic valve, and then inflate a balloon, and after deflation of the balloon, we stop the pacemaker, and then that valve is working immediately. 3 seconds of pacing at 180 beats per minute, and there's a new valve that stays in place due to the severe calcification of the native leaflets. So think of the native calcification as cement. So often a lot of colleagues and everyone else will ask, how does that valve stay in place without suturing, like a surgeon sutures or removes the calcified leaflets? That's how that stays in there. And there's a lot of pre-procedural planning I can talk about. This is My Valve, which is available now in India, and I'm quite impressed with the valve. And it's a more cost-effective alternative than the American valves. More to follow, but a recent landmark trial compared My Valve versus the Edwards and Medtronic platforms and showed non-inferiority at the 30-day and 1-year endpoints of safety and efficacy. So it is a very good valve that, even though Edwards has 20 years of experience, My Valve has a far less experience, and they're producing a very good valve. So we'll get through all of these. These are concerns I have about unmet challenges. This is how we plan for the valve procedure with very good vascular access, micropuncture, ultrasound guided, and we're much safer than previously. Multiple different approaches to TAVR, and then we'll pass through this. These are ways to reduce PVL. I've had discussions with Dr. Jeevan on them where the surgeons have requirements to not have any regurgitation, whereas transcatheter operators, we sometimes accept mild PVL or mild MR after transcatheter procedures, but we have to improve on that and have zero PVL with newer designs. Stroke is a concern, and despite all our research with embolic protection devices, stroke still occurs despite no reduction in 72-hour stroke risk with these devices, so more research required. Pacemaker does occur. We've now gotten better in implanting this quite high. We used to implant the TAVR at 50-50 under the annulus, but now we're at 90-10 or even higher, 100. And it's quite durable. These are the most recent low-risk trials showed only 7%, less than 10% risk of reintervention at 10 years and very low rates of severe valve dysfunction. We are, AI, in the age of AI is pervasive in all of our lives, and AI is in TAVR as well with Dr. Dasi, who's an Indian origin engineer in Ohio State who's developed generative AI predicting complications where I can actually model multiple different valves for my patient to understand coronary obstruction, LVOT rupture, annular rupture, and pacemaker indications. Finally, I want to leave you with this. This is what I was talking to Dr. Prasad about. Swami tells us don't just treat the disease, treat the cause. And now, just with our whole TAVR revolution, we're understanding aortic stenosis even more about how it progresses, how oxidative stress, chronic inflammation, lipoprotein A deposition, so that there are lipoprotein A therapies that can reduce the progression of AS. This is the most telling slide that even during the latent period of myocardial loading, where there's no cardiac damage, there's still a signal for 1-year all-cause mortality and cardiac mortality. And as there's detrimental effects on LV mass, diastolic dysfunction, increased left atrial size, the associated all-cause mortality and cardiac mortality rises. And this is why we're committed to treating aortic stenosis early, and we're getting more and more evidence about not just watchful waiting and clinical surveillance, but trying to treat our patients early before heart failure and mortality occur. So this is in conclusion, TAVR is a mature therapy, indications for TAVR are expanding, and most importantly, we want to pursue early intervention. I'm praying to Swami to allow us to start a TAVR program in Whitefield and Puttaparthi. With his direction, we will be able to do that one day. Thank you very much.